thank you very much and welcome to the Christus Weight Loss Institute. I'm going to tell you a little bit about myself. I am Dr. Peterson. I am the medical director of the Christus Weight Loss Institute. As well, I am an associate professor of surgery at UT Medicine. So this is a combined program. It's a partnership between UT Medicine as well as Christus Santa Rosa. And 3 years ago, we began this program here at the Westover Hills Hospital. And we've become the regional center for Christus to do weight loss surgery, and as well we perform surgery on other patients. I did a fellowship in bariatric and weight loss surgery and minimally invasive surgery at the University of Southern California. And following that time, I went into the military and I was an active duty surgeon. I ran the largest Department of Defense bariatric surgery program in the country here at Wilford Hall Medical Center. And then following that time, I liked San Antonio. I don't know that San Antonio would have been on my radar before the military, but it's a nice place to be and I like it. It's a little hot in the summer, but other than that, I enjoy being here. So partnered up with university, and then we just made this partnership together here. So that's a bit about me. And then what I like to really talk about is my patients. And so I have 3 patients here. These are 3 folks that actually helped us, at least in terms of the marketing, because they're all patients that were from my military time. And this is, Bob is in the top right. Bob had the gastric bypass, and in this picture, Bob is 5 years out after his surgery. When he started out, he's about 330 pounds. He kind of sits around now about 190 to 200. He still attends our support groups quite regularly, and he's about 8 years out now. Lori's in the top left. Lori had the sleeve gastrectomy. That's her at 1 year after surgery. Okay, so in this picture, her claim was that she lost about 72 inches off of her body. She's about 110 pounds down. Lori just celebrated her 5-year anniversary about a month ago. And then Sandy in the bottom left, she had the gastric bypass, and Sandy is 6 months out after surgery in this picture. And Sandy is about 4 years out after surgery now. And Sandy actually happens to be married to Bob. So. And it also turns out that their daughter had surgery with me not too long ago, and she does some of the pictures as well. So real patients, real pictures. This is not stuff that we found off the internet and things like that. These are real people. So one of the things I like to have prospective patients do is come to our support group. We do a support group once a month. It's on the first Wednesday of every month at 6:30 across the street at the Marriott Courtyard. And I want you to meet my patients. I want you to talk to people who've had the surgery, so that if you're not sure what surgical procedure you wanted or you're not really sure, I mean, they tell the story better than I can any day of the week. Okay, I'm passionate about what I do, but they tell it better. So today, our plan is to go through and talk about what are the risks of remaining morbidly obese. So what I want you to understand is morbid obesity as a term is not a mean term. Morbid goes along with comorbid conditions, so other medical problems. So there's a level of obesity at which other medical problems become very prominent. Okay, so that's really what that means. And then I want you to understand what are the surgical options for weight loss, because that's what we do. And then there are some risks and there are some benefits. So it's not all rainbows and butterflies. You need to understand that. You need to know that you have to be prepared that there may be some complications along the way. But understand too that the benefits far outweigh the risks of the surgery, okay, in the long term. And then how do you go forward from today? And we'll talk about that. And then hopefully at the end of the seminar, you agree that this is the place you'd like to start your journey. What I want to do is talk to you a little bit about obesity in the United States and put everybody sort of on the same page. So when we talk about obesity, what's really easier for us to define is something called the body mass index. Because if I tell you this patient is 200 pounds, doesn't really mean a lot, because if they're 6.5 feet tall, that's a really skinny person, and if you're 5 foot tall, it's a very different scenario. So the body mass index actually takes into account height and weight and comes up with a number. Now it's not perfect. The football players who are all muscle, their BMIs are high, but it's not the same kind of thing. But it's still pretty close to the general population. So a BMI of 18 to 25 is considered the normal BMI. A BMI of 25 to 30 is considered overweight. A BMI of 30 and above is considered obese. And then when we start getting into BMI 35 or 40, we start talking about morbid obesity, and that's when medical problems really start to come into play. So the Centers for Disease Control in 1985 started tracking obesity rates in the United States. They didn't have a lot of data then, but you can see there's a couple of states that have an obesity rate of about 10 to 14%. And if we go 10 years later, then we see about half the United States is into the new category of about 15 to 19% of those people in those states are obese. Only 5 years later, we have another category that can take up 1/3 of the US, and that's about 1 in 5 people in those states are considered obese. 5 years later, 2 new categories, both of which kind of occupy into that same area of 1 in 3 and 1 in 4 people in those states are considered obese. In 2009, Colorado was the last blue state in the United States, and in 2010 they lost that. So there is no state in the United States of America that has an obesity rate less than 1 in 5 people. And as you can see, 2/3 are in the 1 in 4 and 1 in 3. And if you look at Texas, right where we are, we're in the 1 in 3 category. So what does that really mean to you, and why do I talk about that? I want you to understand that obesity is not a disease of individuals, it's an epidemic problem. Okay, so you're not alone, and it's not just about diet and exercise like the popular media might want you to believe. It's actually, there's a lot more to it. It's a complex problem. The American Medical Association in 2013 defined obesity as a disease. Before, it's always been just considered a problem, but it's not. It's a disease. Those of us who've been treating obesity for a very long time know it's a disease. So, but they finally came through, and so you can understand. Now that the Centers for Disease Control stopped tracking this data in 2010, we haven't seen any new maps from them since. Morbid obesity. It is the first leading cause of preventable death in the United States of America. 50% of cancer deaths in women are from obesity, 30% of cancer deaths in men are from obesity. Most type 2 diabetes is caused by obesity. I can take the maps that I just showed you, wipe away the title of obesity, and put type 2 diabetes. It looks exactly the same. Okay? Most sleep apnea is caused by obesity, most cardiovascular disease and high blood pressure is caused by obesity, and over 400,000 deaths annually can be attributed to complications of obesity. So there are some associations, some of which I've kind of just hit on. When obesity is present, then high blood pressure is there, type 2 diabetes, sleep apnea. Those are the big 3. Gallbladder problems, heart disease, cancer, osteoarthritis, cholesterol problems, urinary incontinence. I mean, these are the major things that are there. So, and another one on there, reflux disease, okay? Other obesity-related problems. Well, physical things, getting clothes. So finding clothes that fit can be difficult. I had a patient at 3 months out, he was so excited after surgery to tell me that he just bought his first pair of jeans at Walmart for 17 bucks. Because he had to go to the Big and Tall store before, and those jeans were an unnamed brand for $70. So cost is there. Getting around can be difficult. Seating in theaters, airplanes, and restaurants, they're not all made for one size fits all. You know, if you watch, there's a video on our website of Bob talking about, you know, his journey and how he would walk down the airplane aisle when he was traveling before he had surgery, and everybody looking out the window saying, "Oh, please don't sit next to me." You know, there's a bias in our society, and we have to try to work through that. There's an economic and social impact. You know, employers are not supposed to be biased, but there's a hiring bias. Okay, 2 people come in to have a job interview, and one is obese and one is not. There's a really good chance that the person who's not obese is going to get that job. Community as a whole. So this is sort of that last bit of a soapbox that I stand on, and most of it's mostly facts after this point. But you know, shows like The Biggest Loser, while they're really exciting to watch, I don't really think communicate to the community and the public at large that obesity is really a disease. What they're telling you is that diet and exercise are enough, right? Because those shows do that. But the problem is that they have a personal chef 24 hours a day, 7 days a week, and they have a personal trainer 24 hours a day, 7 days a week. So I don't know about you, but I live in the real world where that's not, readily accessible. So it is fine, and those are components of a healthy lifestyle, but they are not the only thing that will drive you to lose weight and have your weight stay down, okay? So what do the experts say? Well, I can tell you there's a recent change back in 2013, which was last year at our first inaugural Obesity Week held in Atlanta. But in 1991, the National Institutes of Health released a consensus statement on obesity saying that surgery was the most durable treatment for long-term treatment of obesity. Okay? 23 years ago. 23 years ago, death rates with surgery were somewhere between 7 and 10%. So that's not an insignificant number. That having been said, it was still considered the best treatment for obesity. Now, 23 years later, the American Heart Association, the American College of Cardiology, and the Obesity Society all put together a list of guidelines based on the recommendations and guidelines of the NIH consensus statement, as well as other groups like the American Society for Metabolic and Bariatric Surgery, going towards saying that surgery is the right thing for patients in the long term. What I can tell you today is death rates from surgery in trained surgeons' hands who do it laparoscopically are somewhere in the range of about 0.1%. So that's a big difference, okay? And so why do all of these societies here support that? And that's the National Institutes of Health, the Obesity Society, the American Society for Metabolic and Bariatric Surgery, which I am a member, the American College of Surgeons, which I am a member, the American College of Cardiology, Heart Association, the American Association of Clinical Endocrinologists, who were one of the last groups to jump on board, but they realize that even with all the best medications that they have, when we do surgery for type 2 diabetes, it wins every time. Every time. And it helps control diabetes, even if it doesn't make it resolve completely, it controls the diabetes better. The American Society for Bariatric Physicians and the Society of American Gastrointestinal and Endoscopic Surgeons, as well as the Academy of Nutrition and Dietetics. So 1991, you had one group who said, "Hey, do it." Look here now, 23 years later, we're a lot more supportive of it. So who qualifies for surgery? What I can tell you is on this slide, what you'll see is that this is a basis for what most insurance companies utilize for qualification for surgery. It's our program as well, and they're kind of based on the 1991 consensus statement guidelines. So the body mass index above 40, you qualify for surgery. Now, I'll put a little asterisk there because your insurance, you may have an exclusion on your policy, but I just want to let you know as an individual, if this is you, you qualify. And then your insurance, that's a separate issue that we will work with you to figure out. If your body mass index is 35 to 39, then you have to have another medical problem associated with that. And if it's type 2 diabetes or sleep apnea or hypertension, one of the big three, then that's it. You only need one of them. If it's not one of those, then something like reflux disease, osteoarthritis, cholesterol problems. And that's going to be somewhat insurance dependent because some insurances are going to say, well, this is a cardiovascular risk factor. So we'll work with you to figure out what that is. You have to be unsuccessful with previous weight loss attempts. So this means that this is not the first thing for you. This is not the first time you've ever tried something. And I will tell you, in the 8 years I've been doing this, I have only had one person ever come to me and have never tried something before. So we know that you've already tried. What your insurance company may say, though, is that you have a 3-month supervised weight loss or a 6-month supervised weight loss. In very rare circumstances, it's a year. Okay? Most are more progressive now and don't require any supervised weight loss because, frankly, they already know what you've done. And there's been no data to say that doing a supervised weight loss before surgery for that length of time correlates with outcomes after. Okay? You have to be ready to change your life and let surgery be successful because it's not going to be enough. Surgery alone is not enough. And I know you coming here, this is not a quick fix. You understand that. I know you know that. Some people may be telling you it is. It's not. It'll be really hard for you to do. But I will tell you that the benefits after the work you do will be better than any other program you've tried. And you have to agree to a lifetime of medical follow-up. So what I can say about that is things are going to happen after surgery. You may have problems. Things may hurt. You need to see a bariatric surgeon to follow you after your surgery. That follow-up care is critical. You know, your primary care doctors, many of who have referred you to me today, they're very good at what they do, but they may not be as familiar with the sort of long-term problems that a bypass or sleeve patient or a band patient may have. So it's important that someone who sees those every day is involved in your care, and if something's happening, we can take care of it sooner than later. So let's talk about the surgical options, and we're going to go into them in some detail, but what you'll see up here is we do 3 surgeries here. We have the lap band, and that's a device that a company actually markets, and you may see it in magazines, so you may be more familiar with it from a popular standpoint. The gastric bypass, it's not an accident that it's in gold up there. It is the gold standard by which we measure all other weight loss operations. And then the sleeve gastrectomy is the third option for surgery. So I'm going to talk about each one of them a little bit. I will show you a quick picture of each of them. And if you have that form, you can take a look now and follow along with the pictures. But the lap band is considered sort of a less invasive surgery. It's slower weight loss over 2 to 3 years, and you can expect to lose about 40 to 50% of your excess weight loss at 2 years. And it's considered reversible. I want you to keep in mind maybe the term might be better considered removable, okay? The gastric bypass is the gold standard, quick weight loss over the 12 to 18 months, and you can expect to lose 70 to 80% of your excess weight at 1 year. It's a very different time frame. And it's considered irreversible. In very rare cases, we can undo it. It's a revision surgery, but it can be undone, but you want to think of it as irreversible. And then the sleeve gastrectomy is moderate but quick weight loss. As well, at 1 year, you can expect to lose about 65 to 70% of your excess weight. And it is, of the 3, irreversible. And I'll kind of explain why that is. If you compare the weight loss of all 3 of these operations, if you look at the red line, that's the lap band. It's a slower weight loss over time. The sleeve gastrectomy is the yellow and the gastric bypass is the blue. They mirror each other more closely, but maybe what you're noticing is that there's a little trend at about 3 years for patients after surgery. So what does that really mean? Well, when you do medical weight loss or exercise, diet, pharmacotherapy, all these other things, the studies today tell you that only 2% of patients will maintain their excess weight loss at 5 years. So that's not really a high number of people. If you look at the surgeries all combined, 85% of patients maintain their excess weight loss at 5 years. Okay, so that's pretty significant. But that means that 15% don't. And who are that 15%? Well, the 15% are people who stop coming to support group. They're not dieting the way they did before. Maybe they're not exercising the same way. And I mean, not that they completely quit. What I'm saying is someone who is exercising 5 days a week says, you know, I'm feeling pretty good. Maybe I'll do 3 days a week. So now you've taken 2 days out of your regimen. How about you can eat more? Because you'll be able to eat more as you get farther out. You'll never be able to eat the whole thing like you did before necessarily, but you'll eat more. And if you add a cookie in there or add something else, you know, 100 calories a day over the course of 1 year is 10 pounds. So it slowly creeps up. What's 100 calories? 2 Oreo cookies.
What?
How about 3 Hershey's Kisses? Right? None of that seems like a big deal, right? You walk by somebody's desk, you grab a Hershey's Kiss, you know, 4 hours later, you grab another one. Well, before you know it, it's there. So you kind of have to watch out. So being mindful of this will help you maintain your weight loss over the long term. So this is kind of the show me the money slide in the sense that how does the surgery impact your medical problems? Well, if obesity starts to go away after the surgery, then you're going to have a 90% improvement in your type 2 diabetes. You're going to have a 75% improvement in your sleep apnea, a 92% improvement in your high blood pressure, 98% improvement in your reflux, 95% improvement in your cardiac function over time, 87% improvement in urinary incontinence, 97% improvement in cholesterol problems, 82% improvement in osteoarthritis, and a 60% reduction in your risk of cancer over the rest of your life. Okay, so these are the surgeries. Okay, we'll go into them in some detail. So I'll talk to you about the gastric bypass. So all 3 surgeries share in common this thing. They're all restrictive. Okay? The bypass is the only one that has this other component, the malabsorption. Okay? So it sort of works on 2 fronts. So normally when you eat food, it comes into your stomach churns it up, food goes out here. The pancreas, which you don't see in this picture, empties some enzymes as well as the liver, and those enzymes help break food down, and you absorb it pretty normally throughout here, and everything goes down to the end, okay, and it's absorbed normally. In the bypass, we cut the stomach and create a small pouch. Pouch is the size of my 2 thumbs, or about the size of an egg. So about 1.5 to 2 ounces. Okay, so not really large. So that's the restriction component about how much you can take in. Then we cut your small intestine and bring it above the stomach. So you see the Y forming here, because that's what it kind of looks like when we're done. And then we bypass the stomach, the gastric bypass. So from a surgical term, this is called the roux limb, so that's where the name comes from, the roux in Y, gastric bypass. So we connect that small intestine to the stomach pouch at the top, okay? So that connection's about the size of a dime. So it's like an hourglass. The food fills into the small pouch, it stays there longer, and so you feel full longer. So you're not as hungry. And so there's the other sort of secondary level of restriction. Then the third component is the malabsorption. So this intestine is no longer down here. It's no longer getting the enzymes from the pancreas and the liver to help absorb the food better. So you eat a food item and you're not going to get all the nutrients and calories from it while it's in this area. Okay, so you won't absorb everything it's supposed to. When it comes down here though and meets up at this area where things are emptying into it, then you'll absorb pretty normally. Okay, so that's how that works. I can tell you, I do this surgery differently than everyone in this city. I'm one of 8 surgeons in Texas that do it this way, and I'm one of about 40 or 50 surgeons in the country. I hand sew this connection up here, okay? So I use a stapling device to make the stomach pouch, but I put the connection together by hand, okay? So is that a better technique? I think so personally. So it's good. Now, this is not to disparage anyone who uses the stapler, because I just told you about 40 or 50 of us in the country do it this way. There's a lot more surgeons than that do weight loss surgery, and they staple. And the stapling device is very good. Okay, so just understand, I just want to let you know that that's what separates me in this area from other people. Okay, well, let's talk about the bad though, because it's not all good things. You need to know what can possibly happen that might not be good. So there's going to be 4 things on each of the slides about the surgeries, about the complications that'll be common. Death, we need to talk about that. DVT, or deep venous thrombosis, or a blood clot in your leg, for example. Pulmonary embolism, that's a blood clot that goes to your lung. Infection and bleeding. Okay, those are all 4 of those are on every slide. If we go straight to the death rate, so let me tell you that the published data on this surgery for death rate is 0.4%. So, but I can tell you the real-time data, okay, all surgeons doing this surgery who are working towards centers of excellence, meaning specialized centers for weight loss surgery, all contribute to a national database, okay? The national database, I can go type it in right now, and I can pull up the death rate for the first 30 days of after surgery and tell you that it's 0.1%. So that's where that number comes from, 0.1%. That's very low. In fact, that's better than somebody who has their gallbladder or appendix removed. So very, very good because of all the things we have in place today. A blood clot in your leg or going to your lung is about 1% or 0.5% respectively. That's all 3 operations, okay? Infection is really rare with all 3 of the operations. It was a thing of the past. You heard about people who had big open gastric bypass surgery. Well, when patients are diabetic and obese and there's a lot of fat and you've had a big incision from stem to stern, that doesn't heal very well. We're talking about laparoscopic surgery where incisions are typically no wider than my index finger. So those incisions usually heal quite well. Bleeding, I've taken a couple of patients back to the operating room for bleeding after this operation. I've had one that had bleeding along the staple line. I've had one that had a bleed here at this small connection site, okay? And I've had one that had bleeding actually on the entry point of the abdomen, the trocar site. So the trocar site one and the bleeding at the staple line, those patients all went to the operating room the next day and stayed 1 extra day in the hospital. The person who had the bleed down here at this connection site, by the way, I don't use the stapling device that I did for that procedure anymore, and I haven't had that problem since. That particular person, we didn't notice the bleeding till day 2, which is about when you'd find it because it's a little bit farther down. And so we took him to the operating room, took care of that, and we kept him in the hospital 2 extra days. So in general, though, after surgery, you have a surgery on, let's say Mondays or Wednesdays, those are my typical days, you're usually home by Wednesday or Friday. So it's a typical 2-day stay. So 1 extra day in the hospital wasn't that much of a problem for those individuals. Leak, the national leak rate, it's about 1% for the gastric bypass. Stricture rate, so what does that mean? Well, I talked about that size of a dime connection. So when we put that together, we want to make sure it's small. If it's too big, then you don't feel full for very long. Things go through more quickly. If it's too tight, of course, you don't tolerate things very well. But when we put 2 pieces of tissue together in a circle and you scar it down, it may scar inward and it may tighten up. So if you end up having a stricture, that's going to be somewhere about 6 to 8 weeks after surgery. We'll notice that. So because you'll probably be starting to tolerate regular foods and then, you take a step back and now you can only do liquids and things. Again, why it's important to have follow-up, because when you let us know, then I'm going to go ahead, talk to you about it and say, you know what, we probably need to go take a look. What we can do is fix that. We can put a camera in your mouth and go down and use a balloon and open that area up. Okay? So the national rate is somewhere about 5% for strictures, and mine is somewhere about 3%. So I'm pretty happy with that. Is that because of the hand sewn? I don't know exactly. I would think so, but I don't know that there are probably other factors involved too. Ulcers, you can develop ulcers after this operation, so you have to be careful. I put patients on a ulcer reducing medication for the first year, or not an ulcer reducing, but an acid reducing medication that helps prevent the ulcers. If you smoke, you'll get an ulcer. If you're taking non-steroidal anti-inflammatory medications, aspirin, Aleve, ibuprofen, Celebrex, these kinds of things, that can lead to ulcers because it decreases the protectiveness of some mucosa by the stomach, okay? So you've got to be careful. Bowel obstruction, that can happen after any surgery we do, but because we're doing some rerouting here with the intestine, there is a potential that we create an area that has an opening. Now we close all the defects in the surgery, but we're closing fat to fat. So a testament to your weight loss is the fat thins out. And if it hasn't scarred down really well, it can develop that. So again, that would be something that's usually very late. So again, following up and saying, hey, Dr. Peterson, I've been having some belly pain off and on. Let's take a look. Let's think about that, because I want to make sure it's not that. And then vitamin and nutritional deficiencies. Well, this has some malabsorption. But what I can tell you is you're going to need to be on a supplement after all 3 surgeries. It doesn't matter which one you choose, okay? Because you're not going to get everything that you can take in today. Most of us get most of what we need out of our daily diets. But you'll have to be on that for the rest of your life. You have to think of it as part of your eating. You may look like a pill, but it's just part of what you do. So I haven't had any patients who have nutritional or vitamin deficiencies because we follow that at every one of your visits, and we're going to check. Okay? And we're going to recommend to you that you take some bariatric or weight loss specific vitamins that actually are really well absorbed. So we'll work with you on that as well. Lifestyle changes after surgery, well, that's pretty consistent with all three of them. Small meals, 4 to 6 times a day, no high calorie foods, and dumping syndrome. Well, dumping syndrome, you're only going to see it with the gastric bypass. And what does that mean? Well, it's a side effect. It's not a complication, so be aware of that. But when you take in a food item, like a cookie, for example, now remember, we rerouted your intestine, so your small intestine that's up there at that small pouch doesn't know how to handle a cookie. Because before it was processed, it looked very different. It had been packaged already, right? Up there, it's not packaged. It's like, I don't know what to do with this. What do I do? And so it floods in some fluid into your intestine because it can't break down the sugar well. You get a little clammy. You don't feel good. Your heart rate starts going a little fast. You might sweat, and then you have some diarrhea. And that's not fun. Okay? So patients only do that once or twice. As I said, it's a side effect. It's really a potent behavior modification tool. Okay? Most people don't, keep doing that to themselves. B12, after this operation, because the way we reroute your intestine, we do disrupt how B12 can be absorbed. So B12 is pretty critical. It used to be that you get an injection once a month, but that was about 10 years ago. Now we have great B12 supplements that are actually in a lot of the bariatric vitamins specifically already. And if not, you take a supplement that goes under your tongue and dissolves in about 5 seconds. So, and then exercise is very critical, obviously, for all 3 surgeries. All right, how about the adjustable gastric band? So the adjustable gastric band is only restrictive. So that's all it does. It just limits what you can take in. It is a medical grade silicone device that's on the upper part of the stomach that goes around. It's a ring that we put around the stomach. It has a balloon on the inside connected to a tube that's connected to a port that is sewn underneath the fat on the strength layer of your abdominal wall. So we use a needle to go through that and access the port and add fluid or take fluid out as needed. So what that does is it fills the balloon and makes it tight or loose. Okay? The area above the band is about 1.5 to 2 ounces, just like the bypass. So we're creating a pouch of about the same size. The difference here is that anything that goes by the band, you keep. Right? So calories. So milkshake. Anyone want to guess vanilla milkshake at McDonald's, medium size, calories? 600. How about a caramel macchiato from Starbucks? Come on, there's a few people. Come on, we like it. It's about 600-700 calories. What? 600 or 700 calories. Yeah, I know, right? And the reason I say 600 or 700 because I never remember what the sizes are called. I don't even know. I ask for medium and they look at me like I'm crazy. But anyway, so that's it. It's liquid calories that go by very fast. Okay, so you've got to be careful with something like this. So, well, let's talk about the surgery, and it's got some things that happen too. The death rate here on that national database is probably somewhere around 0.05%, about half of the bypass. Okay, blood clot is the same, 1% and 0.5%. Bleeding is very rare, infection is very rare, but these things in the middle, going from erosion to port complication, are all specific to the band. So the erosion is something that happens when the band has been around the upper part of the stomach for too long, it's too tight, not being monitored, and it can work its way through the tissue of the stomach and go inside. Okay? So that's a problem. That's an emergency that's got to come out. Okay? I have yet to take out a band put in the United States. Not that they haven't happened, there definitely are, but I've taken out over 20 bands from Mexico for this problem. It's not to say that the Mexican surgeons are doing a bad job, it's just that there's no follow-up typically. That's the problem. So you've got to have the follow-up. The pouch or esophagus can dilate. It can get larger. So if you're going to take something and tighten up something at the end of it, a garden hose is a great example. You put the thing on the end of it to spray and you turn it to off. If you turn on that water and leave it on, you'll see the garden hose bulges. Well, this is kind of what you're doing to your esophagus over time. You're letting it bulge. And it's a lot softer than a garden hose. So if that esophagus dilates too much, then we're going to have to take the fluid down and hopefully it'll recover and it'll be okay. In some cases it doesn't. We have to take the band out, okay? And if it doesn't recover, then the esophagus that's a whole other story that we have to talk about. The band can slip, so you're not immune to getting food poisoning after any of these operations. You're not immune to the stomach flu. You may eat something wrong that gets stuck at the level of the band. And so when those types of things happen and you're vomiting a lot, or pregnancy, that's another one, a lot of vomiting, then that part of that stomach can actually push up through the band, through that little ring, and too much of it gets above the band. And if that happens, then that can be an emergency. We got to go right in because it could be cutting off the blood supply to the stomach. Sometimes it's a chronic problem, meaning that you just don't tolerate liquids well. I've definitely had some people who've come to me that have had a chronic slip and they're vomiting every day and they don't know why, and we find that. When that happens, it's got to come out. That's my opinion, okay? If a band slips, you're done with the band, okay? There will be other practices that'll tell you that if you have a band slip, that the new bands are set to unlock them and try to reconnect them. The problem is that the band, because it's a foreign object and made out of silicone, your body creates a capsule around it, around the outside of it and around the inner aspect of it. So that's kind of a slick capsule. And so if you take it off, or if it slipped and we fix it and get things down and tighten it up again, there's still that slick area that can happen. So that's why, in my opinion, it's just one time it's out, okay? The band, something that maybe not tolerated well or is not that effective, okay? So these two, slippage and ineffectiveness of the band, are the number 1 and 2 reasons why we take out the band. Port complications, that can happen. The port might flip. Now, these types, with the lap band, it's a device where we suture that. There's another company called the Realize band. I actually don't use that one, but you may have heard of that. But the lap band, we suture it in 4 places, but if one of those stitches pops, then we got 3 left, we're okay. And if 2 of them break, then the little port can flip over. And if the port slipped over, we can't access it and we can't adjust it. So that's something that we can, under a local medication, try to fix. But I will tell you, all comers in here, in the United States today, 40% of patients will have the band removed at 5 years. In Europe, it's 50%. And that number is rising every year. Okay, so just be aware. Australia has the best results with the lap band, and the best studies come out of there because they have a system that's a lot different than ours. They have a socialized system. Their primary physicians, primary care physicians, all are very well versed in this and actually do a lot of the adjustments. So a lot of follow-up. So it's just not something we can replicate here in the US, and a lot of the systems in Europe aren't able to replicate either. So just be aware. There's data out there, but more surgeons today are taking more out than they are putting in. Okay? Does not mean this is a bad operation. It's good for the right individual. We just have to figure that out. Small, slow meals here. Absolutely no regular sodas or milkshakes, mostly because we're talking about the calories, right? That's just the liquid calories that are just go through very quickly. Things like steak, white chicken, reheated foods and pasta and breads will cause problems. And you're like, well, why are they all related? They're all related because they all act like a sponge. If you get any of them wet, they expand. So if you're not real sure, you can do a little experiment when you go home, take a little Tupperware, fill it with that, put a piece of bread in it, walk away, come back in 15 minutes, see how much bigger it is. And that's what happens. So when it's going down your esophagus, it's going to get bigger. So it may obstruct, so you got to be careful. White chicken, it's very dry. Now if you reheat food on a cooktop or in an oven, probably going to be okay. It doesn't dehydrate the same way it does in a microwave. So be aware of that. Diet sodas, you need to sip them. So this band is very good at keeping things down and It's a one-way valve kind of thing in a sense. So if you drink your soda a lot and your stomach fills up with a lot of gas, it's only going one way. It's not coming up, and it hurts until it goes. So follow-up is critical. You've got to see me every 4 to 6 weeks for the first year, okay? Because we need to know if we're going to do adjustments. The average number of adjustments for a patient after a lap band is probably 6 or 7 in the first year. We used to put really big adjustments when we first started doing this, okay? But we found that that didn't work well. If you make the band too tight, you don't help the patient. If it's too loose, you don't help the patient, okay? There's this very nice fine zone in the middle where we want you to be comfortable. If it's too loose, you're hungry all the time, okay, and you have no restriction. If it's too tight, you can only have liquids that, like ice cream and shakes and stuff like that. You can't eat the protein that you want and need. So the other zone is where it works and you feel restricted and you feel good and you're able to take all the right things. So that's why the follow-up is critical. We're not going to do an adjustment every time. We'll just determine for you, okay, are you feeling full? Are you hungry? You can eat whatever you want. And if those questions depends on how you answer them, we'll do an adjustment or not. The band is reversible, but so is the weight loss. So be aware, this is not really one of those operations you want so you can get down to the weight you want and then take it out. I'll tell you that people who have that thought when they start, by the time they've lost the weight that they wanted to, they don't want it out. They want to keep it because it's helped them get there. And it's very true. So a young lady who I was called to see over at Baptist Hospital and Medical Center, she had been pregnant, delivered a baby, and had been having a lot of vomiting at the end. She'd had her band done in Mexico, and she had a slip. We took out the band, and within 3 months, she'd gained 50 pounds. So be aware, it's real. Now, I would have never thought that kind of weight gain, but it happens. Now, not everybody gains that much, but they gain. I have yet to have a patient who I've taken a band out of that hasn't gained some weight, for sure. The other thing is it's not, as I said, we say reversible, it's really removable because it does distort the anatomy a bit. So when we remove it, we don't put your stomach exactly back the way it used to look like. We just, you can't undo it completely. But that doesn't mean it doesn't leave it open for a revision or something like that later. And then exercise, of course, is very critical with this operation. All right, sleeve gastrectomy. So this operation is purely restrictive as well. And honestly, that's about where its similarities with the band sort of end, because they both are just purely restrictive. What we do here is we put a tube in your mouth while you're sleeping, and then we use a stapling device, and we cut along that stapling device, or we cut along that tube rather with the stapling device as it's sitting in your stomach. And that tube just sort of calibrates the size of the stomach. So that tube is roughly the size of my index finger, okay, in terms of its size. What I can tell you is we end up removing about 80 to 85% of your stomach. So this is gone. This comes out. So that's why it's irreversible, because the pathologist gets your stomach. You can't have it back, okay? However, that tube we used, we take it back out. It's just there to guide, okay? But what you want to know is what size tube is your surgeon using. Why is that important? Because it relates to leak rates. So you know, I use a 40 French bougie. Okay, that's the term of that's what the tube is called. It's a bougie. So 40 or higher, the leak rate is about 0.6%. If it's lower than that, then the leak rates are upwards of about 2.8%. So just be aware. That's when we've looked at studies correlating, and this is one of the newer surgeries. I say newer, we've been doing them pretty routinely since about, 2010 for sure is when insurance companies started actually approving this surgery. I've been doing it since 2008 because in the military we didn't have to worry about insurance like that. We were TRICARE, we worked on the base, and it didn't matter. Okay, so we've been doing them since then. So you need to know, and we've had a learning curve over that time too. But the most recent data came out about that size of the bougie. Okay. So this particular stomach size now holds about 3.5 to 4 ounces. So a bit bigger than the bypass. But honestly, that may tell you the difference in why there's a little bit difference in the weight loss. That having been said, the malabsorption also may be a part of that. Either way, those are averages, because we certainly have patients who lose more than the average weight loss. Okay, so let's talk about what could not be good here. Well, the death rate here is somewhere more close to the bypass, about that 0.1% range. Blood clots and pulmonary embolism are the exact same as the other two. Bleeding, so I can tell you I've taken 4 patients back to the operating room for bleeding in this operation, all of which have been along that staple line up top. And one of them was a band to sleeve conversion, so the tissue is a little thicker. But all of them just stayed in the hospital 1 extra day. So as an extra anesthetic, of course, and an extra operation. But you'll find that I am very aggressive in that sense. I do not sit on someone who looks like they're having a problem. I would much prefer to go in and be wrong. I haven't gone in and been wrong. We found what we were sure the problem was and took care of the bleeding. So also, as you can imagine, I don't leave the operating room with like, oh, that little oozing, that's going to stop. No, we stay until it's dry. But sometimes blood pressure and other things can be a factor. Sometimes it's also it's a balance, right? We're going to give you something after surgery to try to prevent blood clots from forming in all 3 operations. It's called Lovenox, so it thins your blood a little bit. So we're kind of rolling the dice in a little way, but I'd rather you not have one of these 2 problems. And I can take care of bleeding. This is a little harder to fix, okay? Staple line leak, well, I told you what the leak rates are. The program that I ran at Wilford Hall, we had done 300 sleeve gastrectomies by the time I had left in 2010. And our leak rate, we had 2 patients who had leaks in that process, okay? But having said that, one of the patients was eating regular food on day 3. What? Yeah, what, exactly. What? Exactly, that's not the plan. The plan is liquids for 2 weeks and a pureed diet for 2 weeks, and you're just very gentle. You're very gentle with this new stomach. Okay, stenosis, so narrowing, just like in the bypass, it can happen here. Since I've been doing this, I've only had 1 patient with a sleeve that ever had a narrowing, and we did 1 dilation with a balloon and she was fine. So it's pretty rare. In the beginning, when we were kind of learning the technique and trying to, when you're getting around this narrower, this picture makes it look real easy, but a lot of people's stomach might look more like a J or something. And so this little corner can be a little tight to get around. So, but now we just generally go around it more widely than we used to, okay? Worsening reflux. So if you have really bad gastroesophageal reflux disease, this could make it worse. So we just have to kind of weigh that. Why do you have the reflux? You can revise this to a bypass. So this is the one sort of ability to change this operation. This operation can be converted to a bypass if necessary. In that program of Wilford Hall, we only had 2 patients of the 300 who needed to be converted to a bypass for inadequate weight loss. And honestly, that was probably because those were patients earlier in our experience where we were a lot more worried to hug that tube real close, so their stomachs were probably a little bit bigger. But that again, over time, as we've learned, has changed. But the other thing, the asterisk on that is that your insurance company may say you have a lifetime benefit of 1 surgery. So we may talk about revision to bypass if there's weight regain, but you may not actually have the benefit. And the truth of the matter is I want you to get the right operation the first time. I really don't want to plan on coming back and doing another operation later. Okay? So keep that in mind as we go forward as well. So small, slow meals, no regular sodas or milkshakes. Again, like the band, anything that gets into the stomach of the sleeve, you keep, right, if it goes by. So it's just like that. High-calorie liquids can be as detrimental as well. You may still need to be on anti-reflux medications, although I tell you most patients are off of any kind of acid-reducing medication by 3 months. Exercise, again, is critical. So, what is right for me, right? So you've talked about all this, Dr. Peterson. How do I know what I should get? Well, the bypass has proven long-term results. It's highly effective, no foreign objects. If you have bad reflux or esophagitis, this cures that. It is a cure for that. If you have really bad type 2 diabetes, I'm going to suggest you get this, because this is the best operation for type 2 diabetes of all three of them, hands down. I will more than likely have you off of your diabetes medication the next day. This operation works differently than the others in that. Now, if you've been diabetic for less than 5 years, probably a really good chance you're going to stay off those medications. If you've been diabetic for more than 10 years, we're gonna have a harder time. But that having been said, we're going to control your diabetes a lot better. The gentleman who was on 300 units of insulin a day on a pump did his gastric bypass, had to do some sliding scale insulin coverage immediately after surgery and following along. A year after surgery, he's getting 15 units of insulin a week. So he's not off his diabetes, he's not cured from his diabetes, but it is way better controlled. So I point out extreme cases and things, but the truth of the matter is those extreme cases are really good examples. I mean, these are typical results for patients. So the sleeve gastrectomy has similar close results to the type 2 diabetes. Dr. Phil Schauer did a study in the New England Journal of Medicine in 2012, March of 2012, where he showed and demonstrated that the sleeve gastrectomy had very good results when it came to type 2 diabetes as well, which for the surgeons was actually a really neat thing, because we didn't know that the sleeve was as good at its type 2 diabetes resolution as well. So it was nice. Nice for us to see that. Adjustable gastric band, so it is removable, highly compliant, so you've got to have lots of visits, so be ready for that. And if you can do that, then this is going to be successful for you. Less vitamin and mineral deficiency risks because you're not doing any malabsorption, so you expect that most anything that gets by you'll keep. Low risk of major complications, meaning the bleeding and the leaking, but you have to be willing to accept that there will be minor other complications. And when it comes to beyond 30 days, because we talk about 30-day mortality and morbidity, after 30 days, the lap band has the highest complication rate, upwards of, we're talking 40%. The sleeve gastrectomy, no foreign objects, opt to revise to bypass if there's weight regain, as I kind of alluded to before. Low risks of major complications compared to the gastric bypass, although they're similar. They both have bleeding and leaking. They're both similar. Less vitamin and mineral deficiency risks here, of course, no malabsorption. You can take non-steroidal anti-inflammatory medications here, so this might be one of the reasons why we choose this operation. If you have really bad arthritis, maybe this is what we do for you. Okay, you're not going to necessarily develop an ulcer with that. Absorption critical medications. If you're on Plavix, if you're on Coumadin, if you're on an epilepsy medication, then this would probably be a better operation for you, because the absorption is not going to necessarily be disrupted like it might be in the bypass. And then if you have inflammatory bowel disease, vasculitis, or lupus, those are contraindications to the other two surgeries, and this would be your surgery of choice. So in the program, you've already accomplished half of the first red one here. Got the initial seminar down. So then we'll set up an appointment to see me individually, because I can now sit down and customize what's going to be the best treatment for you. I have 3 options, and we're going to figure out what may be best. All 3 might be perfect for you, and I'm not going to force anyone to have any kind of surgery. You're going to make that choice, and hopefully it's an informed one that we've gone through. And then you're going to do some things. Supervised weight loss. We put a question mark there because that's purely insurance dependent. If your insurance company says 6 months, there is nothing I can do to make it shorter. I wish I could, but I can't. Again, there are a lot of progressive ones that are 0 supervised weight loss. If you don't have insurance benefits and you were paying cash, we don't have a supervised weight loss requirement. I would follow what the most progressive insurances do, which is 0. Support group, I want everyone to go to support group. I want everyone to attend and meet one of my patients and talk to them and hear how surgery affected them and changed their life. Nutrition and psychological workup. So some of you may have met Anna, our dietitian, who is wearing the light blue scrubs outside. She's our dietitian. Everyone will meet with her. And she will be there in the aftercare visits as well. She'll be there to see you after surgery. So it's not just a one-time thank you. She'll be there all the time for you. Psychological evaluation, everyone meets with our psychologist. You have to go through that process. That's an insurance requirement. It's a program requirement. Sleep studies. When you come to see me for the first visit, we're going to give you a questionnaire, and you'll go through that, and we're going to determine how high risk you are for having sleep apnea. Some of you may know you have sleep apnea. You're being treated for it. That's fine. I'll need reports of that. If it's been a while, we may need a repeat study. But 90% of people who come see me who are don't know they have sleep apnea or don't think they have it end up having it. So the questionnaire is pretty accurate, and we'll go through that. I do an endoscopy on everybody because if I'm going to alter your stomach in any way, I want to know what it looked like before I do that. And on a couple of occasions, what I've found has changed the surgery that we were going to do. Okay? And everyone gets blood work. Maybe you don't know you're diabetic yet. Maybe you don't know you have cholesterol problems. Maybe you don't, or maybe you do, and now we need to see, we want a baseline because we want to watch how well your diabetes or cholesterol or other problems are improving. And of course, we're going to also follow your vitamin levels and things like that all throughout that process. Surgeon evaluation and pre-op. So this is the sort of the last step. So you've gone through all of these other things here. They're all being done in parallel. And by the time we get to this point, this is where you're going to make the decision about what surgery you would like for sure. Okay? It may be the same one we decided in the red box at the beginning, and that's fine. It may have changed because of things we found along the way. So either way, it's just at that time we make that decision for sure, and we submit at that time for pre-authorization for surgery. So Cindy's pretty good about this already. Cindy knows, how long the insurance companies take, but in general, we kind of give ourselves a cushion of about 30 days. That's why there's a little gap. Your insurance company has 30 days to respond and tell us whether you're authorized for surgery or not. Some cases they'll call and say, oh, nope, you missed this, this, or that, and we think, no, and I have to get on with the medical director, and I do medical director peer-to-peers all the time, and in general, it's usually, oh, I didn't see such and such on that page. Yep, we faxed it to you, you have it. So usually that's not a problem. Everyone that goes to surgery is going to do a preoperative liquid diet for 2 weeks, and it's a high-protein, low-carbohydrate liquid diet. This serves one purpose, and that is to shrink your liver. You're going to shrink your liver about 20%. So if your liver, which may be now sitting far here onto the left side, is in the way, if it shrinks about 20%, it gets out of my way. If it's out of my way, it's technically less demanding. If it's technically less demanding, that means it's safer for you. So safer surgery is what we all want. Okay? And then there's an expectation of weight loss because when you do it, most everybody loses weight on it. I just don't have a specific percentage or number of pounds you need to lose. You just need to do the liquid diet and you'll see the results of that. Okay, so that's a lot about the program. I'd like to open it up for questions for you, and we'll go from there.